Hello. So let's get started. This is a joint seminar between the Department of Biostatistics and Data Science and the Institute of Implementation Science at UTHealth. We are delighted to welcome Dr. Wang from University of Massachusetts Medical School. Bo is a good friend of mine. I think we know each other almost more than a decade now. So we were colleague at Wayne State, and then we worked on several grants papers continuously, still working, submitting grants. So Bo has a very illustrious career. Like, he got his MD degree from Lanzhou Medical College in China. Then he got an MPH, followed by a PhD in epidemiology and biostatistics in 2002 from Fudan University. He did his postdoc from University of Wisconsin-Madison in 2004 in HIV prevention. Bo is a very successful grant writer. Like, I do not know exact count of how many grants he got. Right now, he's running 4 major grants, like R01, and then R34, R21, and continuously submitting grant on HIV prevention. For example, we worked together on the Bahamas HIV prevention study, school-based prevention study. He is also working on Thailand, for example, on transgender and MSM subjects, the prevention. He's also expanding his work on Zambia. So basically, he's a global health researcher in true sense, in US, in Asia, Africa, everywhere. So he is going to present today a talk on national implementation of an evidence-based HIV prevention program among Bahamas adolescents. I believe I'm part of this research. So Bo, the podium is yours, and we will take any question probably at the end of the lecture. Thank you.
Yes, thanks. Hi, everyone. I'm from University of Massachusetts Medical School. I have been conducting research in HIV prevention and implementation science research in Bahamas, Thailand, and Zambia. But today I will focus on Bahamas study, national implementation of evidence-based HIV prevention program among Bahamian adolescents. I will give some background. Over the past 3 decades, significant progress have been made in the field of HIV prevention. CDC identified 60 based evidence effective HIV prevention programs as part of diffusion of effective behavioral interventions initiative. Dissemination efforts has resulted in an increased number of evidence-based interventions being implemented among expanded population in the past decade. Research found implementation efforts face multiple challenges in real-world setting. For example, intervention decay and the lack of any intervention effects. Community-based providers often selectively implement program components or significantly modifies the intervention, which impairs program outcome. Prevention programs implemented in schools are typically not implemented with high quality. For example, on average, teachers only taught 50% of curriculum. More information is needed about factors influencing real-life implementation and long-term program impact. Our national implementation of focus on use in the Caribbean in the Bahamas offers a unique opportunity to examine patterns of implementation over time and also relate them to student outcome. This is the first R1 that we received. This R1 addresses a few questions. To what extent did the teachers implement FOYC intervention with fidelity in their classes? And do teachers vary in their degree of implementation? What factors influence the teachers' implementation, and what is the relationship among influence factors? And last one, how do teachers' initial implementation of FOYC and the subsequent delivery of booster sessions impact student outcome in grade 6, grade 7, and grade 8? First, let me talk about the evidence-based intervention. It's called FOYC. FOYC stands for Focus on Use in the Caribbean, which is adapted from Focus on Use. Focus on Use and informed parents and children together are currently part of the CDC DEBI portfolio. FOYC is life skill curriculum designed to reduce risk-taking behaviors related to HIV, STI transmission, and teen pregnancy. FYC curriculum has 8 sessions, each average 45 minutes to 1.5 hours. And we also have a 1-hour annual booster session delivered in grade 7, grade 8, grade 9, a review decision-making model, condom use skills, and communication skills. This is the overall study design. FYC was integrated into an existing Bahamian curriculum called Health and Family Life Education in 2011. At the beginning of grade 6, teachers attended a training workshop. Teachers also completed the pre and post implementation questionnaires at the beginning and at the end of grade 6. And FYC was delivered to grade 6 students. And grade 7, grade 8, grade 9 teachers also attended a teacher training workshop, delivered one session, FYC booster session in grade 7, grade 8, grade 9. And the students completed surveys at the beginning of grade 6 follow-up, and also grade 7, grade 8, grade 9 follow-up. And the student surveys collected information on HIV, AIDS knowledge, condom use skills, self-efficacy, risk behaviors, and intentions. Teacher completed the implementation checklist. Study site. Our study includes 80 government primary schools and 34 middle schools in 12 Bahamian islands. New Providence, the capital island, has over 50%, nearly 50% of teachers and students. Participants, we have 208 grade 6 teachers, 75 grade 7 teachers, 58 grade 8 teachers, and over 4,400 students initially in grade 6 and followed for 3 years. And the follow-up rate was high in grade 6, but it was 95, and 78 in grade 7, 74 in grade 8. And the Ministry of Education launched the 11 teacher training workshop, and about 60% of teachers attended the FYC training workshop. Measures. Fidelity of implementation is defined as adherence to core activities in 8 sessions, and the teacher completed the implementation checklist. There are 30 core activities. And those is defined as number of core activities that were taught. And the factors associated with the implementation were collected through pre and post implementation questionnaires. Teachers' education, years as teacher, attendance at FYC training workshop, teachers' training in interactive teaching, perception of the importance of HIV prevention, confidence in teaching FYC lessons, competing priorities, and perceived student benefits. These are all collected from pre-implementation, post-implementation questionnaires. And we also have student outcomes. HIV/AIDS knowledge, it was a 15-item scale, including true and false statements. And the preventive reproductive health skills, it was a 6-item condom use scale, describing steps of correct condom use. And the condom use self-efficacy, 3-item scale, and the intention to use condom protection, it was a single item. We first conducted cluster analysis to identify teachers' patterns of implementation. And we used 2 indicators, number of core activities completed and the percentage of core activities being changed. So these are 2 indicators for class analysis. And we also run linear mixed effect model, examining teachers' implementation and student outcome. Finally, we run structured equation modeling, examine relationship among factors influence teachers' implementation and student outcome. It was a 2-step process. And the starting model, implementation model, was first estimated to examine relationship among influence factors using teachers' data. And then we built a 4 model by adding grade 6, grade 7, grade 8 teachers' student outcome, and also teachers' delivery of booster session into the model. Results. We actually cover implementation clusters, factors influencing teachers' implementation, and student outcome, and also teachers' modification of curriculum and student outcome. And finally, we actually combined student outcome in grade 7 and 8. Grade 6 teachers implementation and grade 7, 8 teachers delivery of boost station with student outcome. Teachers on average taught 16 core activities from the 30 core activities, and taught 4.6 sessions from the 8 sessions. And the teacher changed the 3 core activities on average. 1/3 did not change any core activity, and 1/3 changed 1 to 3 core activities. Approximately 10% of teachers changed more than 10 core activities. This is the results of cluster analysis. We identified 3 implementation clusters. As you can see from this measure of cohesion and separation, our cluster quality is good. And the 2 indicators are important for this cluster analysis. And 31.7% teachers belong to high implementation group. As you can see here, 31.7%. And these teachers on average taught over 80% of core activities, 25 or more core activities, and changed only 14% of core activity. And the largest group is a moderate implementation group. It has 52.8% of teachers. And the teachers taught less than half of core activities, changed 13% of core activities. The smallest group is a low implementation group. And these teachers on average taught less than 1/3 of core activities. They only taught like on average 8.6 activities, and changed 3/4 of core activities that they taught. This table looking at influencing factors influence teachers' implementation. This is actually a characteristic from pre-implementation. Can see here, teachers' attendance of training workshop, teachers' training in interactive teaching, comfort level in teaching FOYC lessons, and working in Capital Island, New Providence. These factors are positively related to high implementation group. This table look at the post-implementation perceptions. Teachers' perception of the importance of FOYC, and teachers perceive the benefits of FOYC curriculum for grade 6 students, and program ownership. Teacher consider FOYC is a Bahamian curriculum, and also teachers' comfort level in teaching core activities. And these factors are positively associated with high implementation group. Having other priorities negatively associated with high implementation group. This is a mixed model. Look at teachers' implementation and student outcome. Student outcome, we have 4 outcomes: knowledge, skill, self-efficacy, and intention. And you can see compared to low implementation group. And students whose teachers belong to high implementation group or moderate implementation group, they actually demonstrated better student outcome, better knowledge, HIV/AIDS knowledge, better condom use skills, self-efficacy, and intention to use condom protection. Teachers' modification and student outcome. So here, we actually categorize the teachers' level of modification into 3 categories. And the comparison group did not change FOYC lesson. As you can see, students whose teachers heavily modified FOYC lesson demonstrated poorer student outcomes, lower actually HIV/AIDS knowledge, self-efficacy, and intention to use condom protection. We also look at grade 6 teachers' implementation, initial implementation of FOYC, and the grade 7 teachers' booster delivery with grade 7 student outcome. As you can see here, when we look at this implementation in grade 6 and grade 7 together, and the grade 6 teachers' implementation associated with HIV/AIDS knowledge and intention to use condom protection. And grade 7 teachers' level of delivery of booster session related to HIV knowledge, economy skills, and intention to use condom protection. We also look at this mixed model, look at different combinations of grade 6 teacher is implementation of FOYC intervention, and grade 7 teachers delivery of FOYC booster session on student outcome in grade 7. And we are using high implementation of FOYC and good delivery of booster session as a reference group. As you can see, students whose teacher, students had a low is implementing teachers in grade 6, and also low is implementing teacher in grade 7. And these students demonstrated poor student outcomes. As you can see, their HIV/AIDS knowledge, condom use skills, self-efficacy, and the intent to use condom protection all lower than students who had a high-performing teacher in grade 6 and grade 7. And students whose grade 6 teachers belonged to low implemented group, but grade 7 teacher had a good delivery of booster session. And these group students, their knowledge is, their outcome is not significantly different from reference group. Then we look at actually grade 6, grade 7 grade teachers, grade 6, 7, 8, and student outcomes with teachers is implementation. And this actually is a result from stratification modeling. Teachers' attitudes toward FOYC, teachers' level of comfort with FOYC lesson predicted teachers' implementation, and which in turn predicted student outcome in grade 6. And teachers' attendance of FOYC training had a direct effect on teachers' implementation behavior. Grade 7's booster delivery predicted grade 7 student outcome. Grade 8 booster delivery also predicted grade 8 student outcome. So this is a ACA model. And so from this study, we learned implementation of FOYC varied greatly among teachers. And we identified the 3 implementation cluster. And it's significantly related to its improvement in all students 12 months, that means grade 6 follow-up. And a high quality initial implementation of FOYC combined with good delivery of FOYC booster session resulted in improvements in long student outcome. And the teachers' heavy modification associated with poor student outcome. And we also found poor subsequent delivery of booster session in grade 7 can undermine positive effect from the initial implementation of FOYC in 6th grade. And also strong booster delivery can partially overcome poor initial implementation in grade 6. So there are several limitations in this first R1. It is possible teacher over-report the level of implementation. We have observed 20% of teachers classroom teaching. We compare the teacher and observers' reports on activities covered in the classroom. And we found the teacher and observer agreement is high. It is over 80%. And we also collected school level data from school administrators, but we only collected this data from half of participating schools. So school level factor was not analyzed in this first R1. There was a relatively high attrition rate to grade 7 as 22%. This is because actually students graduating from 6th grader, and also some students, they transfer to a non-government middle school. So we study actually government primary school, government middle school, and government high school, but the private school is not part of this study. There was these limitations. And so this was first R1, it was closed in 2017, and then based on this study, we applied a new R1. We are developing theory-driven implementation strategies to increase the sustainability of teachers' implementation. This, our first R1 is, the finding is consistent with other study. It was a standard Euro implementation, and the teachers only delivered slightly over 50% of curriculum. And to address this implementation challenge, we developed actually 2 to 3 strategies. These strategies including innovative teacher training, webinar, short video clips, and bi-weekly monitoring and feedback, site-based assistance and mentorship. So this strategy are developed during the second R1. The objective of this R1 is to determine if multi-level implementation strategy increase the national implementation fidelity to 80%. That was a high performer teacher group reached this fidelity level, and the result being sustained implementation over 4 years over time. So here in year 1, this is 2019, we conducted a pilot MOOC to identify ideal training and implementation strategy for at-risk teachers. During the first grant period, we developed a 7-item pre-implementation screening tool, and we use this tool to identify teachers who are at risk for not implementing the curriculum in the classroom, and moderate high-performing teachers. And high-performing teachers serve as mentors for low-performing teachers. And at-risk teachers, moderate-performing teachers participated in a factorial experiment. I have 6 conditions here. So this is year 1, and is limited to New Providence, Capital Island. And we are trying to identify a strategy for at-risk and moderate performing teacher. And then from year 2 is nationwide deployment. So this is the year 1. Some results, we have some results. Now this table, this graphic compares Euro's implementation with the enhanced implementation. Euro's implementation is the first R1, enhanced implementation, second R1. And we are comparing data from year 1, initial implementation. As you can see, enhanced implementation, teachers delivered 7.2 sessions versus 4.4 Euro's implementation. And enhanced implementation period, teachers taught 28.3 core activities versus 16.3 in 2011. So teachers in New Providence, this is actually limited in New Providence, but when we talk about Family Island is suboptimal later. Teachers in New Providence taught over 80% of intervention curriculum in 2019 to 2020, despite massive disruption caused by COVID-19. So it was we were excited about these results. Now, as you can see, teachers continue the implementation of FYCC's impact over the past 4 years. This table limited to New Providence. So 80 teachers in New Providence. As you can see, this over the past 4 years, teachers continuously teaching actually over 80% of curriculum. They taught 7.2 sessions, 7.6 sessions, 8.3 sessions, 8.1 sessions in different year. And the core activities, 20, year 1, they have 28 core activities, year 2 covered 25.5 core activities, year 3, year 4 have 28 core activities. I think 2020 to 21, COVID was a big problem. And as you can see, teachers' implementation is slightly lower than other years. Now I want to talk about teachers' implementation in remote Family Island. This actually, Family Island implementation is suboptimal, and it was severely disrupted by COVID-19. These teachers on average only taught 55% core activity, which is similar to our Euro implementation that first R1. First R1 taught like 51, 52%, but this second R1, although it's called enhanced implementation, but Family Island teachers, the performance is not very good. They only taught 55% core activities. There are several reasons. First is site-based assistance and mentorship was not deployed in schools in Family Island due to school closure, travel restriction because of COVID. So, as you can see, teachers in Family Island, they did not receive much support as the teachers in New Providence. And also in some family islands, religious beliefs and local culture, it was an issue. And many teachers think this sex education should be taught by parents, not teachers in classroom. So they have these perceptions. And also concerns about the program content. Condom use skills actually is a very important component for this adolescent risk reduction intervention. But this actually, because of religious reason, this actually content is, many parents have concerns and they have pressure on teachers as well. They think actually teaching condom use skills will promote sexual activity. And also they have, some teachers has misconception because as you know, this Bahamas HIV prevalence reduced by 40% in past decade. And HIV AIDS related deaths reduced by 60%. So some teachers really think this HIV prevention is less important. Although they are capable to teach this curriculum in their health and family life education class, they did not do it. And another reason is teachers are isolated in family island. Family island is small, they only have one school and one teacher. This one, family health and family life education teacher could not get help from peers. But in New Providence, Capital Island, each school they have multiple teachers teaching this curriculum. They can help each other. So there are many reasons, and we are actually developing a new R1 to address this challenge. Challenge is relatively low implementation in Family Island and also some schools in New Providence. So I work closely with Samuel and Gush developing this three-stage, too many threes, smart design. We are, as you can see here in year one is stage one. Stage one is, again, UTHealth implementation, providing teacher training only in year one. At the end of year one, we will actually examine teachers' checklists, identify these teachers who are non-responders, who are not meeting expectation of 80% curriculum development. We actually define it as core activities. If these teachers are non-responders, we are randomize them to two arms. One is bi-weekly monitoring and feedback. The other is bi-weekly monitoring and feedback plus site-based assistance and mentorship. So we are actually determining what is added benefits of SAM. This SAM we kind of developed in first, second R1, but because it's not fully deployed, and we examined in year one, it was a pilot most, but it was not fully evaluated during the 4-year implementation because it's not fully deployed. And then, as you can see, at the end of year two, we identify non-responders and randomize them to more intensive intervention group. And this design is called adaptive implementation. And we are going to compare UTHealth implementation, teacher training only versus enhanced implementation. We also going to compare the effect of bi-weekly monitoring and feedback with bi-weekly monitoring and feedback plus SAM to determine the added effect of SAM. And eventually we will identify most effective implementation strategy for non-responding teachers. So we are already kind of working with the school districts, co-developed a strategy called enhanced SAM. The enhanced SAM, we are still piloting, testing it. It has not finalized. We still have 1.5 months to submit the proposal. So this proposal actually also have another component. It's called precision HIV prevention. We are using novel deep learning approach to predict adolescent non-responders. Adolescents received our HIV intervention, but their outcome did not change, or they increased and relapsed. So this is, outcome is based on condom use skills, condom use self-efficacy. We are using this deep learning approach. And also we're going to identify teacher and school characteristics associated with poor student outcome, non-student non-responders, and to inform nationwide implementation. So this is a new component. And more, recently we also secured our new R21. Working with Samuel Gush, we actually developed this actually 2-year follow-up study among these actually 80 teachers in New Providence, and also qualitative interview among 24 school coordinators who were monitoring teachers' implementation, 12 high-performing teachers who served as peer mentor for low implementing teachers involved in national implementation study in the past 4 years. So this study leveraged our decade-long implementation research. And we are actually going to combine data from last 4 years implementation phase with this 2 years follow-up. So we're going to basically investigate implementation trajectories and determinants of program sustainability. These R21 will also evaluate sustainment, identify multi-level determinants, examine impact of teachers' modification, adaptation on teachers' implementation fidelity and student outcome. Yeah, I speak very fast, I'm nervous. And I can take questions.
Please speak your name and if you have any question.
I got a question. So thank you, first of all, for your great presentation. So I wonder whether the teachers who are not responding to the program or the teachers who are not implementing the core activities will get penalized. And another follow-up question is, are you planning to follow up with the students when they graduate from the school or when they become adults, whether they will get HIV?
Next. Thank you for the question. And teachers actually, yes, Ministry of Education encourage teachers teach this comprehensive sex education program in their classes, but they are not, they are not forced to teach this curriculum. Yeah, it's their decision to how much they teach or what session they will cover in their health and family life education class. And this class is a Friday afternoon, and sometimes actually also got canceled. Yeah, so this actually is teachers' decision to deliver this evidence-based intervention in the classroom. In terms of long-term follow-up for students' student outcome, yeah, we put together R1 kind of for those students from middle school to high school and until they graduated. So that R1, we received very good score in first round, but not second round. So that was not funded. We are looking at employment, HIV rates, STI infection, a lot of them is long-term follow-up of students graduate, who received our intervention in grade 6. Now they already graduated from high school, and most of these students are still in Bahamas, and we connected to their classroom monitor, the teacher, and I did, found their phone number and social media, all this. But it was not funded by NIH because they think it's very hard to reach a high number of this group of students. So we don't have this data.
So thank you for the presentation. It's a very interesting study. So my name is Cici Bauer, and I'm associate professor in the Department of Biostatistics and Data Science. I would like to know a little bit more of when you say you wanted to use some deep learning algorithm to predict a non-response. I think in a lot of the surveys, the very big challenge is not able to get a lot of these information, and the sample size wouldn't be usually as large as other data sets. So could you just elaborate a little bit more of how you plan to collect the information and why do you think the the deep learning algorithms might be better than other, more traditional approaches in predicting the non-response? Thank you.
Thank you. Here, this precision prevention idea, I have been working on this topic for 2 or 3 years, actually. We are building a model with Dr. Yesen actually currently on using actually high school student data. The idea is, yes, we collecting student data in grade 6. So we have baseline data. We are using baseline data build a model to predict students who are likely to be non-responders, so that we actually can deliver targeted information. But not for this R1, we are not actually give them targeted information because we have not developed one. We are using advanced machine learning versus statistical approach because we have many variables. They are kind of, they are high correlated. The relationship are, are complex. So we are trying to use this advanced machine learning build a prediction model because we have at least like 80 predictors. Our sample size is, you're right, is not very big, but still over 4,000. For 4,000 students, we are following from grade 6 until grade 9. Thank you.
Like CC, like one of the reasons is that deep learning is fundable. Let's be clear. Deep learning is more fundable. The other reason is that what Bo is telling, like there are many features. Like we have like features which doesn't line up properly. So basically, yeah, we can use logistic regression or similar kind of classification approach to, or lasso-based approach essentially. So we will use some of the traditional approach. At the same time, we will try to see like, if deep learning does better job in capturing the information. So it's not just one approach. It's the one approach, and then we'll also stack up traditional ML-based approach to see how they perform.
Yeah, I have a similar question actually. When we try to use this deep learning, we never show the benefit compared to the traditional statistical prediction methods. If our data are structured, it's like when we work on the EHR data, usually we have several thousand of predictors. Sometimes we even put 20,000. With sample size, it's quite big, sometimes have 2 million predictors. Even that complicated data, but all this deep learning does not work as well as simple linear model or simple standard machine learning model. So that's usually this kind of model works for those unstructured, like the imaging, that's no problem. But for any of the structured data, we cannot find any, maybe, include AUC a little bit sometimes, but that's just random, sometimes not. So that's the thing, we don't want to argue with people. Most of the cases, standard statistical model is almost same as this complicated deep learning in terms of prediction.
Yes, thank you for your input. Thank you.
Chin will tell us like if deep learning could do beat.
I mean, I asked my students, find a structured data that for all the computer science or deep learning literature, people show that this learn or LSTM model better than standard model. You still cannot find any paper. All that they show the benefit is from imaging or text. Almost all the papers talking about this deep learning better is about imaging or unstructured. They cannot find any structured data to show this. That's what.
That's very helpful. Thank you.
And I have also a couple of suggestions here. Like we both published several papers, but like in Statistics Journal, we published 2 papers. I'll give you a couple of examples, like what kind of statistical modeling challenge that we can get. So as you can see, by the very description, the data have 4 or more levels. Because you see, you have like region, under region, you have like school, under school, you have class, and then every class has a teacher who delivered this preventive education. So then whom they deliver to the student. So there is already 3 level, 4 levels stacked up. And then you can have observation that is repeated measure. Like for example, so basically you have 4 level, 5 level data. It's like how you see the levels. Now when you do, even if you don't do anything fancy, but simply design clinical trial, which is like 4 level data, 5 level data. So the the simple calculation of sample size and power is not straightforward. Because what is your sample size? Sample size is your student, is your school, is your class. There's so many. Like we have to talk about N1, N2, N3, N4, all these levels. So when we start writing this kind of grant, typically make a approximation. That means you ignore upper levels and then calculate sample size. I think there's a good book by Dooner, for example, who does the similar job for 2 level. So one of my friend in Cornell, like when I was there, they developed method for 3 level. But what about 4 level? What about 5 level? So that give us impetus to write new paper. Of course, NIH will not fund you your biometrics paper. You have to get funded and then you start working on it. So I come back to you. So we develop methods for example, our sample size power calculation under different assumption for 4 level and 5 level data. Yes, Sisi.
Yeah, I understand you're gonna have to follow where the money is, right? So I understand using maybe deep learning as a way just to make the proposal more attractive to get funded. So since we are on this topic, if you're using some of the deep learning approaches, especially in the clinical trial design, how do you usually justify sample size in the design?
Very good question. So the deep learning is taken as an exploratory aim. It's not a primary aim because you cannot do sample size and power. So that's the thing I do when I go to NIH review. You do sample size and power for some model, and then you do deep learning, which has nothing to do with the sample size power calculation model. So this is an exploratory aim, okay, this aim that you are seeing. The other topic that I will talk about, like which we are working and almost finish up our paper, what about subgroup discovery? So subgroup discovery is a standard like challenge in any clinical trial. But we are talking about hierarchical cluster level data and not just 2 level cluster. It's like 4 level, 5 level cluster level data. And subgroup can be at different level. For example, subgroup can be at the student level. Typically, we talk about subgroup at the patient level, the lowest level, right? Like high performing students versus low performing students, or whether female students are doing better than or worse than the male students, or if the classroom size does matter in terms of like when you do the preventative education. So that's a level of subgrouping. But what about the subgrouping at the teacher level? Like Bo talks about high performance teacher versus low performance teacher, high motivational teacher versus low motivational teacher. So you can have subgroup at different levels. And you are talking about subgroup discovery. So it's a very, like when we start working on the paper, we could not find any article where they talk about subgroup at different hierarchical level. They talk about subgroup at the lowest level, that's it. But nothing in the higher level. But this kind of data, because Bo is running this R01 for I think more than 12 years, I think three R01, like with Dr. Stanton and then you. Yeah. So we have so much data about, like for example, where you can do subgroup discovery. So basically we thought we will write a paper in StatMed, but there is so much math, I don't think it will go to the StatMed. So this kind of grants give us impetus to write statistical paper. So you don't see statistical method in the aims, but if you dig deeper, you can write tons and tons of statistical paper. We are just scratching the surface. Thank you. Any more questions? If there is any question from the WebEx people, you can unmute yourself and ask question.
If nobody asks a question, I can ask another question. For your first study, you talked about the teacher income and teacher cluster. Is that you did the latent cluster analysis or according to the?
Oh, that is not a latent class analysis. It's traditional class analysis. Class analysis.
Yeah. How do you define it? High, medium?
Oh, it's a cluster. You just is a class analysis. This is traditional cluster analysis. You actually providing indicator variables. You're right.
So basically, yeah. I think what you did, like you come up with different cutoffs, like 3, 4, 5, and then you see like
manual cluster.
Yes.
Not
No. It's not a manual. You don't provide cutoff. Yeah, it's. I think SPSS have this procedure. If you provide indicator variables, so actually program will run actually classify teachers into different clusters based on this indicator variables. These indicator variables, one is number of core activities covered, the other is the percentage of core activity being changed. And as you can see, we have measures of cohesion and separation indicating this class quality.
So basically some kind of goodness of fit versus the cluster number. So basically, like you can see the elbow where so it's like a more exploratory approach. So if there is no question, I'd like to thank everybody and thank Dr. Wang for giving a nice presentation. Thank you.